welcome and then I will, the first session will be by Dr. M.T. Krishna, right?
So you will be
I
inviting
will
Dr.
proceed
Jose.
that way.
You will be inviting Dr. Jose, sir, and then you will also be inviting Dr. Danish, and then thereafter
Danish,
invite
yes.
Dr. Thirumala.
Okay.
So, ma'am, we are good to go. Please start.
Good evening, everyone, and welcome one and all to the last penultimate ultimate session of Anaphylaxis Decoded, which is we are having a series of sessions with multidisciplinary approach, recognition and diagnosis in various situations in anaphylaxis. And today, the main topic is perioperative and refractory anaphylaxis, special scenarios. And we have August gathering here with us with many learned speakers. And today, the session chair is Dr. Jose Osuf, who is the former chairperson of our chapter. And we will also have Dr. Danesh Wolvelkar with us, who is the treasurer of the Indian Academy of Pediatrics Allergy Immunology chapter. Our first speaker will be Dr. M.T. Krishna. But first of all, I invite the session chair, Dr. Jose Yusuf, to say a few words.
Thank you, Dr. Sanjukta. I think Dr. Jose is somehow having some connectivity issue. So, never the matters. So, I would like to welcome every one of you on behalf of IAP Allergy and Applied Immunology chapter. And as we understand that we are going through this anaphylaxis week and anaphylaxis webinar series, and today is the third webinar in the series. We have already taken care about the diagnosis of anaphylaxis and the management of anaphylaxis in the emergency room, and then what discharge advices should be given. Then in the second webinar, we have discussed about different triggers. That could be food, that could be drug, that could be insect venom, and what could be the investigations possible which should be done in a particular patient when a patient presents to us. And now today we are going to have a very important anaphylaxis webinar in which we are going to discuss about some difficult scenarios, difficult cases. And I think with me, Dr. Danish Walvaikar is with us. So Dr. Danish is currently the treasurer of the chapter. I'd like to request Dr. Danish to please say a few words, and thereafter we can formally start the session.
Yeah, thanks, Dr. Neeraj. This is a wonderful initiative, and 2/3 of our sessions are over, and last 1/3 and very important session is remaining. And we really have a galaxy of stars and experts for this session. And I don't need any time wasting for this. That we know that this is a very difficult topic, and every expert has made it very simple for us. And I'm also looking forward for this, like everybody else, to learn few tips from each and every speaker. So that's how we can go forward with that to learn more about anaphylaxis. Thank you.
Thank you. Thank you, Dr. Dhanesh. Now I welcome our first speaker, Professor M.T. Krishna, who is the chair of Allergy, Clinical Immunology and Global Health in the Institute of Immunology and Immunotherapy, University of Birmingham. Sir is a well-known speaker, and we are very, very happy to have him amongst us. Sir, without further ado, if you could start your topic on perioperative anaphylaxis during general anesthesia. Thank you.
Thank you. Thank you very much indeed for the very kind introduction. I would like to thank Dr. Gupta and the colleagues from Indian Association of Pediatrics for the very kind invitation. So I've been tasked to talk about this very important topic, which I think is sometimes very challenging indeed, probably the most challenging in the field of allergology, which is perioperative anaphylaxis. Now, and to qualify, it is during general anesthesia. So why do I say it's the most challenging? Now, we are taught in, during our medical school days, during our postgraduate days, that it's all about history, history, history. It's not just about allergy, it's about any medical discipline. But this is one area of medicine where I think that particular point doesn't entirely apply, because your patient is sedated, they're unconscious, they're unable to give you a history. They have gone into the operating theater with a hope that a life-saving surgery or an elective surgery is going to be done for them to improve their quality of life, only to be told when they wake up that actually you had a near fatal anaphylaxis, you had to undergo cardiopulmonary resuscitation, and actually your operation was cancelled. And we need you to undergo some tests to find out what you are allergic to before we can proceed with the operation. And that can be a very, very stressful news for the patient and their family. This happens both in children and adults. I'm an adult allergy and clinical immunology physician, so I don't see children, but I do participate in multidisciplinary meetings where children with perioperative anaphylaxis are also discussed. But I think it is fair to say that the general anesthetic anaphylaxis is more common in adults than in children, probably because it's more number of adults undergo surgeries on a day-to-day basis, not for any other reason. So with that introduction in mind, what I want to do today is to give you an overview. And I'm conscious that we've got general pediatricians who are not allergy specialists in the audience. So I'll try to strike a balance to maintain your interest while not disappointing our specialist allergy doctors who are very keen to know about the nuances of the perioperative anaphylaxis diagnosis and management. So let's see how it goes. So So my slides are not moving. I need to share it again, I think. 1 second. I'll unshare and share it again. Apologies. So,
Sir, just double click it. Just double click it. It will start moving. Double click the mouse, sir.
yeah. So this is my case one. This is a young patient, a female patient who came in for a tonsillectomy. Okay. So this patient had tolerated general anesthesia previously. This is an old slide, so that's why it says 2014. So they underwent appendectomy previously under general anesthesia. And other than some intolerance reaction to tramadol, which caused some CNS symptoms, they have no previous history of drug allergy. They are clinically tolerant to latex and chlorhexidine. That's a routine question asked in the pre-anesthetic clinic. They have mild asthma, which is not really requiring any treatment. They are atopic. They have got allergic rhinitis, and they are known to have nephrotic syndrome. The patient's brother, and there's a family history of penicillin allergy, basically, and the patient is a smoker. So that's the relevant medical history. So this patient underwent general anesthesia. And just for those of you who are not familiar what happens during general anesthesia, you have rapid induction where you're given sequential drugs within a few seconds, literally. And this patient had fentanyl, propofol, and atracurium given one after the other at 10:30 a.m., as you can see. And also to remind all of you that all patients who undergo general anesthesia are exposed to chlorhexidine, they're exposed to latex. So there are a couple of allergens that you may not bear in mind in the context of anaphylaxis. So I'll keep on pushing that idea to you during the presentation. So that's what happened. 10:30, they had these 3 drugs. Then you can see that virtually after the 3rd drug was given, at 10:30, they developed severe bronchospasm, causing rise in ventilatory pressures. There's no desaturation, and they developed urticaria at the site where the cannula was inserted and at the top of the chest. So it was not really a full-blown anaphylaxis. It doesn't meet the WHO criteria for anaphylaxis, but nevertheless, this was a serious reaction in that it did cause lower airway symptoms. But the patient then received treatment for the bronchospasm. They had magnesium sulfate and dexamethasone. The surgery was fortunately completed in this patient at 11:45. And then the patient also had serial serum total tryptase measurements. This is really important. So the first one is done within a couple of hours. after the onset of reaction immediately. The second sample is taken within 2 hours. The half-life of tryptase, as you may have heard in previous presentations, about 2 hours. So you have the first sample taken as soon as possible after the onset of suspected anaphylaxis. The second sample is taken within 2 hours within the half-life, and you have a third sample taken at 24 hours or beyond to get a baseline tryptase. So what you're looking at here is a dynamic increase in the total tryptase level. And in this patient, really, the tryptase did not rise. Okay. And one very important point I want to get across today is just because the tryptase did not rise doesn't mean that the patient did not have anaphylaxis. When you have serious anaphylaxis, the tryptase will rise, but there are a small proportion of patients where the tryptase will not rise. So probably in this patient, because it was not a full-blown anaphylaxis, the tryptase did not rise. So this patient then went on to have allergy skin testing. The way allergy skin testing is done is its first step is to have a skin prick test, and that is with relevant negative and positive controls. Negative control is saline, positive control is histamine, just to make sure that the test is working and the patient is showing a histamine response. And then you add a drop of the different solutions of interest. And if they're all negative, then you proceed with an intradermal test where about 0.02 to 0.05 ml of the solution of interest is injected intradermally to raise a bleb. You draw around a bleb, you look at what is the baseline wheal, and then you wait for about 20 minutes to look at the wheal and flare response. So if there's a flare, wheal about 3 millimeter greater than the negative control with a flare, then that's regarded as a positive reaction. So as you can see here, I've not shown you the data on the skin prick tests. The skin prick tests were all negative, by the way, including latex and chlorhexidine. And this patient went on to have intradermal test. And you can see there that the intradermal test was positive to atracurium, which is one of the drugs given in addition to fentanyl and propofol. So here, the patient, this is a very rare thing. Sometimes a patient can get a reaction to the intradermal test. As it happened in this patient, they developed a mild reaction following intradermal test. They had a whole body itch and some erythema on the upper limb and upper chest, which did not require any treatment. But nevertheless, we nailed the cause of the reaction, which is atracurium. So the question is that next time if the patient requires general anesthesia, what is an alternative? So therefore, we included rocuronium, suxamethonium, and vecuronium in the panel. And what you can see is that rocuronium was completely negative. We have measured the wheal and flare response at 20 minutes and 30 minutes, as you can see there. And you can see that there was no increase in the wheal diameter for rocuronium. And rocuronium is a very good NMBA that is used for general anesthesia. So really, this patient could go on to receive rocuronium or indeed suxamethonium for a future procedure. So what's the next thing we did? Here is we gave the patient a diagnosis of IgE-mediated reaction to atracurium. We said to them that, avoid general anesthesia as far as possible, but if they do require general anesthesia for a future procedure, then they should avoid atracurium and rocuronium can be used instead. My case 2. This is a 53-year-old gentleman who underwent a cystoscopy procedure. He had some very interesting previous medical history which one could not ignore. So they had a urethral stent procedure about 13 years ago. We don't have the details, but soon after the procedure, they developed urticaria and angioedema, which was not investigated. They also gave a history of mild urticaria about 5 to 10 minutes after exposure to a mouthwash used at dental surgery, and they didn't think much about it. They used latex glove at work, and they're clinically tolerant. They also confirmed that they are clinically tolerant to aspirin and ibuprofen. And so really, there's not much to shout about from the allergy history. They had hypertension and they're on Ramipril. So that's the medical history of this patient at the pre-anesthetic check, okay? So again, we did the same thing here. They had the prick tests, which are all negative to the target agents. But before that, let me tell you what happened at the induction. You can see there are more number of drugs given. They had fentanyl, propofol, atracurium, comoxiclav, dexamethasone, cyclizine, diclofenac. They're exposed to latex. And at 1755, they had a urethral catheterization procedure. And Instilla gel is used to lubricate the catheter before insertion. So what you can see here, the timing is really important. You need to pay attention to the time. Between 5:40 p.m. and 5:45 p.m., they had rapid induction with multiple drugs, including antibiotics. At the end of the procedure, they had diclofenac, which was given IV, and they were exposed to latex throughout the procedure from 1755 onwards when the procedure started. And then they were given Instilla gel, as I said before, the urethral catheterization. Now, they developed severe anaphylaxis. You can see here that the induction happened at about 1740. They developed hypotension about half an hour later. They had hypotensive crisis. They had tachycardia, bronchospasm, urticaria, flushing. So it was a full-blown anaphylaxis, which was treated successfully. Okay, and the patient was referred to our clinic. So here you can see that acute tryptase went up to 19 micrograms per mil immediately after the reaction. And then at 24 hours the following day, it came down to 2.7. This is what I meant by dynamic increase in acute serum tryptase. So this is anaphylaxis, no doubt about it. So when the patient came to our clinic, we did prick tests to everything that was involved. They were all negative. Intradermal tests were also negative. And I would just want to pause and ask you, what do you think might have happened? What do you think the patient might have reacted? Now, because we've got a large number of audience, I'm not going to ask you to comment, but you can always put your comments in the chat box. But this patient was allergic to chlorhexidine. It was confirmed with a blood test. We didn't do a skin test because we had a high degree of suspicion that this patient was allergic to chlorhexidine. All the other allergy tests were negative. And the reason I say chlorhexidine is because chlorhexidine is present in the Instilla gel. Instilla gel contains lignocaine and chlorhexidine, and it is often a hidden allergen that is ignored. And it's really important not to miss this diagnosis. So what did we do here? We counseled the patient regarding chlorhexidine allergy. We highlighted to them where chlorhexidine is present, like lotions, ointments, mouthwash, toothpaste, etc. But as healthcare professionals, I want to mention to you a very important point. Chlorhexidine can be impregnated in central lines. So I've known patients who are known to be chlorhexidine allergic, but they declared to the healthcare professional, and they had a central line insertion, and a person who was doing the central line did not realize that there was chlorhexidine in the central line. It was impregnated, and they get severe anaphylaxis. Okay, so this is really important, a good lesson for you to take away about chlorhexidine allergy as a possible cause for perioperative anaphylaxis. My third case is a 66-year-old gentleman. He had an arthroscopic shoulder decompression. The patient has multiple comorbidities: ischemic heart disease, underwent CABG, type 2 diabetes, total knee replacement. They were on multiple medications. They tolerated previous general anesthesia for a CABG and total knee replacement. Okay, and again, clinical examination was absolutely normal, and they were an ex-smoker. Okay, so that's the background of this patient. So again, multiple drugs given between 8:35 and 8:36 for general anesthesia: propofol, alfentanil, atricurium, dexamethasone, metoclopropamide, granisetron, flucloxacillin, gentamicin. Everything was given. The patient had the perioperative phase, or the operation went beautifully, no problem at all. But the patient developed severe anaphylaxis after the procedure. Okay, this is about, you can see here, the patient had diclofenac at 9:35. Okay, and you can see that this was refractory anaphylaxis. They required multiple doses of intramuscular adrenaline followed by IV adrenaline. So that was a severe anaphylactic reaction. Okay, now take a look at the hypotension. Saturation was unrecordable. Blood pressure was 32 or 23. So that's how serious this can be. Look at the tryptase measurement. Acute tryptase was more than 200, and the baseline tryptase was slightly elevated above the baseline at 14.8. So this patient had all the tests done, and they were all negative. And here the index of suspicion was on diclofenac. But diclofenac, we don't go do skin testing to diclofenac. It causes reactions in non-IgE mediated fashion. So there are no reliable blood tests or skin tests. But here, we were suspecting that this patient may have a clonal mast cell disorder, mastocytosis. And that's why the tryptase went up to more than 200. And diclofenac is one of the common agents that can trigger anaphylaxis in the context of mastocytosis. So we had a high clinical probability that this patient may have mastocytosis. They had a bone marrow, and you can see the bone marrow result and the histopathologist's report. And you can see the staining for tryptase in the bone marrow. This patient did not meet all the WHO criteria for mastocytosis, but nevertheless, the patient, has, probably had minor criteria, and we did label this patient as having mastocytosis and advise the patient to avoid aspirin and all non-steroidal anti-inflammatory drugs, and then followed the clinical management of mastocytosis in this patient. So those are my key three cases, and now I want to give you an overview of general anesthesia related anaphylaxis. So you will agree with me that it's a serious, potentially fatal perioperative event that requires prompt treatment, and you're in the best possible hands because you're with the anesthetist there who can hopefully identify the reaction and initiate treatment. It's often associated with severe cardiorespiratory compromise, and we know a number of patients who can go into asystole or ventricular fibrillation requiring cardiopulmonary resuscitation. What are the anaphylaxis mimics? Sometimes you can have patients with isolated bronchospasm that could just be due to a mechanical event due to difficult intubation, or you could have a patient with uncontrolled COPD or asthma who reacts to intubation where there's bronchial hyperresponsiveness causing bronchospasm, or sometimes you can get patients who is hemorrhaging or who has had a myocardial infarction during surgery, and that can mimic anaphylaxis. Okay, so you need to bear in mind differential diagnosis, but when you suspect anaphylaxis, treat it. It's really important. The earlier the management is instituted, the better is the clinical outcome. The incident rates in France are about 1 in 10,000 procedures, 1 in 10,000 to 1 in 20,000, and we have got similar figures from the UK, which I'll share with you in a minute. So what are the risk factors? Anyone who has had a previous history of anaphylaxis during general anesthesia or had a serious event during general anesthesia which was not addressed is a risk for future procedures. Patient with a known diagnosis of mastocytosis are at a risk of serious anaphylaxis during general anesthesia. And patients with spina bifida who are at risk for latex allergy because they've got an indwelling catheter with latex in it, and they can become sensitized to latex, they can develop latex allergy, and then during anesthesia, they might have anaphylaxis in response to the latex glove. So this is some data. A lot of work has been done in France. You can see 3 decades worth of data here. I'm going to take you through that. The first one is 1990, 1991 published. The second one was 10 years later, and the third one was 10 years later in early millennium. And what you can see is that in about a third of patients with suspected anaphylaxis, no cause can be detected. Is it because the patient actually did not have anaphylaxis or your tests were not good enough to pick it up? We don't know that. We're not going to dwell on that. But what is important here is to look at what are the positive triggers. At least in France, the most common about 30 years ago was neuromuscular blocking agents like atracurium and rocuronium. But over the years, you can see that latex became more common. It has gone up from 12.6 to 22%. Antibiotics, 2.6 to 15% because of greater antibiotic use for surgical prophylaxis. And then amongst the NMBA, at least 20 years back, it's rocuronium and succinylcholine. That really reflects the prescription patterns of NMBA or the NMBA used during anesthesia. So the point I'm trying to make here is the common triggers in France are NMBA, followed by antibiotics, and among antibiotics is usually penicillin, and then that's followed by latex. Okay. Now, we did a lot of work in UK. This is our studies. We did 2 studies I'm going to show you. In the first study, again, like France, we could detect a cause out of 161 patients. A cause of anaphylaxis could be underpinned in 70% of the cases. And among the anaphylactic cases, the leading cause in our cohort was NMBA, as we found, as reported in France, followed by antibiotics. And for the first time, we showed that 5% of cases and 6% of cases, respectively, were due to chlorhexidine and patent blue allergy. Patent blue is a dye that is used for sentinel lymph node mapping. So all these patients who had breast cancer surgery, they had an intradermal patent blue for sentinel lymph node mapping, and it can cause severe refractory anaphylaxis. Amongst the NMBAs, we also found atracurium as the most common. This is about more than 10 years ago, followed by, you can see here, rocuronium. And that again reflects the NMBA use in the UK. But when we went back and did the same study a few years later, we found that, again, no cause was detected in about 17% of cases. But amongst the IgE-mediated reaction, we found that antibiotics were nearly 50% of the cases, mostly penicillin, followed by NMBA. But again, here we showed that chlorhexidine and patent blue were about 8% of cases. So this is really important. A good lesson to learn here is antibiotics have become the leading cause, probably because of greater antibiotic use for surgical prophylaxis, and then the chlorhexidine used for antiseptic procedures to paint the skin before surgery, and then the patent blue. Almost all cases were related to breast cancer. Okay, so that's what our data showed. This is a landmark study from the National Audit Project from the Royal College of Anesthetists. And what's really important here is 3 million anesthetic cases were taken for a full year. And the incident rate of perioperative anaphylaxis was 1 in 10,000. And what you can see here is, if you look at the triggers, the last arrow you can see here, antibiotics were the leading cause, very similar to the data we had published a few years before. And teicoplanin is an antibiotic that is given for patients with penicillin allergy label. 95% of cases of penicillin allergy label that patients declare in the clinic are usually inaccurate, at least in the UK and high-income countries. So these patients receive teicoplanin as an alternative, and teicoplanin is very allergenic. The relative risk of anaphylaxis teicoplanin is more than 17. So therefore, another important lesson we learned from this is that, if a patient is declaring a penicillin allergy label, it might be worth investigating penicillin allergy to see whether the patient is really allergic to penicillin, rather than subjecting the patient to teicoplanin, which carries a very high risk of anaphylaxis. And here in UK, we have an unmet need for allergy. You can see patients wait for more than 100 days, sometimes even more. And 1/3 of patients who had perioperative anaphylaxis experienced harm. Most of them developed anxiety after the severe perioperative event. Right. So this is an infographic which I've already gone through. There you can see the relative risk of teicoplanin anaphylaxis is 17. And this is the breakdown of different triggers. And as I said to you, nearly half the cases were antibiotics, followed by muscle relaxants, followed by chlorhexidine and patent blue dye. Now, we need to be a bit of a detective here. We rely heavily on the anesthetist, what information they give us. And if you actually look at the agents that were given, the route of administration, and the time at which these agents were given, then you can actually work out, you can have a pretest probability of what might be the suspect. Now, if the patient develops a reaction within minutes of induction, it is usually due to the NMBA or antibiotic. If the reaction occurs, say, half an hour into procedure, that is usually related to a colloid or due to latex or due to chlorhexidine that the patient was exposed to during the procedure. Now, if the patient develops a reaction at recovery, which is after, say, 45 minutes operation, usually what happens is the anesthetists tend to give rectal NSAID or give them an opiate for pain control, or it could be due to latex. So depending upon the time at which the event occurs, you can have a fair bit of prediction as to what the implicated agent might be, which you can then confirm with skin testing. Now, one of the important things that I want to highlight here is the clinical manifestation. Mind you, patients are draped, so therefore the anesthetist can't examine the skin during an operative event. But nevertheless, the most common presentation is hypotensive crisis and respiratory lower airway involvement. Usually, you don't have enough time for urticaria to develop because the reactions are occurring so rapidly, almost instantaneously after induction. So that's why cardiorespiratory compromise is the most common presentation in perioperative anaphylaxis. Although you do get patients, a small proportion of patients who can develop mucocutaneous symptoms. So what is the pathway? So it goes without saying that the anesthetist is present with the patient. They have to identify a patient with suspected anaphylaxis, intervene early. They give the acute treatment, adrenaline immediately, fluid management and all that, which we are not going to go into details. But then once the patient is stabilized, take the first tryptase sample, and then within 1 to 2 hours, take the second tryptase sample, and then 24 hours or later, take the third tryptase sample to see if there's a dynamic increase in the tryptase level, as I showed you in the first couple of cases. As I said to you, you can still have anaphylaxis without a dynamic increase in tryptase, although in most cases with true anaphylaxis, you would get an acute rise in tryptase. So once you have done all that, the pathway in the UK is to make copies of the anesthetic charts and make a good summary of the perioperative event and refer the patient to an allergy specialist. Now, I want to show you something very important. This is a slide to show the tryptase. You can see that the half-life of tryptase is less than 2 hours. It goes up less than 2 hours, and then the curve comes down. Therefore, you need to get that sample to not to miss the peak rise in acute tryptase. So you do that after you've stabilized your patient, by the way. You should not be doing the blood sample before giving adrenaline, by the way. Now, this is some data from our studies. We showed that the level of tryptase is much higher in patients who get anaphylaxis as opposed to those where no cause is detected, probably because those patients have not developed anaphylaxis. You can see 4 micrograms versus 42 micrograms is the median there. But when you compare non-IgE mediated and IgE mediated anaphylaxis, the level of tryptase, at least in our study, was much higher in IgE mediated anaphylaxis as opposed to non-IgE mediated anaphylaxis. Now, this is another study where we compared the tryptase levels. You can see in patients who came into A&E department, say with chest pain or asthma, their tryptase doesn't go up, whereas almost all cases of anaphylaxis will have a very high tryptase, acute tryptase level. Now, I want to introduce you to the Association of Anesthetists of Great Britain and Ireland, Proforma. This is a proforma that was developed following the NAP6 audit, which I just shared with you. This can be downloaded from the internet. It's free. Okay, here the anesthetist will fill out this form for us because the patient can't give you the history. You can see here the first page of the form is all about the demographics, whether the patient is going to have a future surgery, is it urgent and all that. But the second page is really important. What are the different drugs, what time they were given, what is the route of administration. The second table is about the clinical features, what time the patient developed hypotension or bronchospasm, urticaria, angioedema, and all that. And then this is about whether the patient was exposed to any neuroaxial block and a local anesthetic was given. Was it done in latex-free environment? And what were the other drugs that were given post-reaction? And the last page is about the tryptase results. So really, before the patient comes to our clinic, we have this proforma with a covering letter, which gives you a good account, a good narrative of what has happened. So really, we don't even need to talk to the patient. We just go through the clinical history, make sure the patient is well enough to have the procedure, and then we plan our tests as I shared with you. Now, all the skin tests are done as per the BSACI and the EACI, which is the European Academy of Clinical Allergy and Clinical Immunology guidelines. So we have non-irritant concentrations for all skin tests, so they're all standardized, so we can give the best possible care for our patients. So once we have done everything, we do a letter that is sent to the patient's general physician, to the patient's anesthetist, and a copy of the letter to the patient. And we put it in the patient's clinical records. We ask the GP or the primary physician to put the allergy into their records. We ask the patient to wear a medic bracelet, which clearly states their allergy so that they don't accidentally expose themselves to the trigger next time round, so to avoid any further harm. Now, this is the BSACI guideline, which tells you what's the role of the anesthetist. I'm not going to go into that. I've already described it. What's the role of the analgist? So we all know what our role is. So long as everyone is discharging their duties, the patient gets the best possible care. You can see treatment of anaphylaxis, taking tryptase samples, filling out the AAGBI proforma, doing a covering letter, an allergist, go through the documents, plan the testing, then counsel the patient regarding the results, and do all the different letters that we send out to patient, GP, anesthetist, surgeon, and share a copy with the patient. Now, for all of you who are interested to read about this, you can look into the BSACI guideline. There are AAGBI guidelines. There are the Scandinavian guidelines. So quite a few resources for you to look at. That's the French guideline. They're all more or less saying the same thing, really, but they're all freely available on the web for you to look at. So this is our referral pathway. In my hospital, the anesthetist treats acute episode. They take the tryptase samples as I described, the serial tryptase samples. They complete the AAGBI proforma. They have to type it, by the way. They should not handwrite it. They forward a copy of the drug charts, anesthetic charts with a covering letter. Then the patient is offered an appointment in our clinic. And then once the tests are completed, a detailed summary of the results are forwarded to all those people, including the patient. The patient is advised to do a medical alert bracelet, and then the alerts are included in the patient records and primary care, and we also report to the Medicines Health Authority in the UK about the event. So just to wrap it up, you will agree with me that patients with perioperative anaphylaxis should be referred to an allergy specialist. Antibiotics are the leading cause of perioperative anaphylaxis in the UK, mainly penicillin-related antibiotics. Latex allergy is extremely rare in the UK. I have not pointed out in my slide, but as opposed to France, in UK, we hardly see any latex allergy because this latex-free environment, latex-free gloves are used in routine clinical environments. So the sensitization rates have gone down in the UK, but it's still there in Europe, in North America. Latex allergy is still there, and I'm sure it is there in India as well. And chlorhexidine and patent blue are emerging newer allergens. Then a point to make is that the rise in serum tryptase is a useful adjunct in the management of anaphylaxis. It has got very high specificity and positive predictive value for IG-mediated reactions. And then routine practice, serial time tryptase, and duly completed AAGBI proforma are really important in the pathway. I would just like to thank my team in UHB, my anesthetist, Dr. Hulur, who is there with us for allergy testing, and the Department of Anesthesia, and everyone, including the patients who participated in this audit. Thank you very much indeed for your attention.
Thank you, Dr. Krishna, for this very comprehensive discussion on allergy and perioperative anaphylaxis. There are some questions in the chat box. If I may, sir, shall I proceed with the questions?
Yes, please.
The very first questions come from Dr. Gupta, our chairperson. He has asked that, what is your take on serum-specific IgE versus SPT for drug allergy, especially for anesthetic drugs? And do we need both or either of them in the presence of suggestive history?
Okay.
So serum-specific IgE versus SPT, sir.
That's a very good question. So this is a really important question as well. Now, first point to make is the specific IgE testing for drugs have not been validated. Specific IgE tests are available only for very limited number of drugs. The ones that we can do on immunocap is penicillin V, penicillin G, amoxicillin, ampicillin. We can do for chlorhexidine and latex and succinylcholine. Those are the only drugs for which we have specific IgE. Now, latex specific IgE is quite reliable. Chlorhexidine is very helpful. Okay, but any test, doesn't matter, it's skin test or blood test, has to be interpreted in the context of clinical history, but never get carried away by a negative test, because the sensitivity of serum specific IgE for penicillin is very low. Okay, so in fact, in our clinic, we rely more on skin testing. We use specific IgE testing in combination, but not in isolation. Okay, so the short answer to your question is you will not go wrong by relying on skin tests and use the specific IgE measurements more as an adjunct.
Thank you, sir. I think that is the mostly the guidelines everyone prescribes. So skin prick test is better than serum-specific IgE. Another question is, chlorhexidine serum-specific IgE is not available in India. Is it freely available in the UK? I think
Yes.
not, but I'll let you answer that question.
It's available in specialized labs, all the NHS labs where we have an immunocap, and where there's a drug allergy clinic, chlorhexidine is available. So it can be very easily accessed. That's not a problem at all for us. But again, with chlorhexidine, we use a solution which is diluted as per the IACI guideline.
Hello. Since it is not available in India, what would you suggest in the case of chlorhexidine allergy when we suspect it?
I would do a skin test. I would do a prick
Thank
test followed by an intradermal test at the non-irritant concentration as per the IACI guideline.
Right, sir. And another question again from Dr. Gupta is, I think you have covered it in the presentation. Is what is the mechanism of normal tryptase in case of clinically proven IG-mediated anaphylaxis? I think
Yeah.
you already covered this, that
Yeah,
the tryptase.
the
But
simple
I
answer
think
is I don't know. But what I can tell you is that our research has shown that you're more likely to get a rise in tryptase when you have a hypotensive crisis. I have only a very small proportion of patients you don't have an increase. But again, the point has to be emphasized. Just because you don't have a rise in acute serum tryptase doesn't exclude anaphylaxis. But a rise in tryptase can only be anaphylaxis. It can't be anything else. Now, what is the reason why some people don't have a rise in tryptase? I don't know. I don't think anyone knows the answer to that.
right, sir. There's a question from Akashif Singh. If testing for sensitization to antibiotics, should epicutaneous or intradermal method be preferred?
So the good clinical practice is to first take a history, then do a skin prick test, and if the prick test is negative, then proceed with intradermal test. We do not do intradermal test directly because, as you can see, sometimes in patients with true anaphylaxis, an intradermal test itself can trigger off an allergic reaction. So we are very careful. In fact, even the prick test, sometimes we dilute it tenfold higher than what is needed. Say, for example, with amoxicillin, the standard non-irritant concentration for a prick test is 25 milligram per mil. In someone who has had severe anaphylaxis, where amoxicillin is a likely culprit, we actually start at 2.5 milligrams per mil before going into 25 milligram per mil. So never go to intradermal directly. Do a prick test, make sure it is negative, then do intradermal. And even intradermal, sometimes we start at 2.5 milligram per mil before going into the non-irritant concentration. So you have to take utmost care.
Absolutely, sir. A question from Dr. Akashdeep Singh again, very quickly. Can syrups be directly used for skin prick test to assess sensitization? How common is allergy to preservatives? Can syrups be directly used for SPTs to assess sensitization?
We usually don't. We don't use mixtures for prick test, first of all. And we would never use a mixture, a syrup or a mixture for intradermal anyway.
Yeah, because it will have the sensitization to the preservatives and
Not because of that. It's also because you have no control over the non-irritant concentration. You can get irritant response. You don't know how to interpret it. So we usually we do the prick test and intradermal test with parenteral solutions. We don't use, oral preparations for doing intradermal testing.
Another question, sir, I think the last one for you, from Dr. Lalit Mendirata. I think this is in view of the practice in many hospitals and institutes in India to do a intravenous, before doing intravenous administration, to do a intradermal test or test for antibiotics, which something it has been completely stopped in the NHS. I know that, having worked there, but is it necessary to do an intradermal test for antibiotics prior to intravenous administration?
Okay.
I'll let you take that.
Yeah. So this is what is called preemptive skin testing. And it is done in China mainland also. It is done a lot in India. Now, it is not something that we do in the UK, or I don't know of any other high income country where we do preemptive skin testing. We always ask the question to the patient, before administration of any IV drug, do you have any history of allergy? And if so, to what? We look at their records and see if they've got any alerts there. If not, the patient is given the drug, no delay in management. Okay. Now, I would ask the audience to look into an article which I wrote with Dr. Moitra. I don't know if Saibal is here in the audience. We wrote an article which was published a few months ago in Clinical and Experimental Allergy about challenges in penicillin allergy management in India and Sri Lanka. So I would certainly urge you to read that paper, which provides you with good clinical practice guidelines and a very nice algorithm that you can use. But the short answer to your question, I'm not going to tell you what you should do or you should not do, but what I will tell you is what we do. What we do is we don't do preemptive skin testing. We go by the clinical history. If the patient does not give a history of allergy, then we go on to administer the drug, whatever the drug that might be. If there's a concern about allergy, then either an alternative drug is used or the patient is referred for testing, depending upon how urgent the procedure is. And sometimes the patient gives a history of anaphylaxis and they require, say, for example, you may have a patient with bacterial endocarditis or patient with neurosyphilis or patient with syphilis in pregnancy where penicillin is the ideal drug. And if they give a history of an IgE-mediated reaction, then we do rapid drug desensitization under the supervision of an allergy or immunologist in a safe clinical environment with immediate access to anaphylaxis management and critical care. Okay, so that's why I would urge you to go to this article we published a few months ago, which addresses exactly this question that's been asked.
Thank you, sir. Thank you so much for such an excellent and exhaustive session. I now invite Dr. Joseph, who is our past chairperson of the allergy chapter, who joined us a little late, but to say a few words, sir, before we progress to the next session. Dr. Joseph, please. Sir, are you there? Dr. Joseph, are you there, sir? I am not able to connect with him.
Dr. Jose is there. Dr. Jose is there. Yeah.
Is there? Okay, excellent. Dr. Jose, please, can you say a few words, sir? So we have a past chairperson of the allergy chapter here with us tonight.
Thank you, Sanjuta Day, and congratulations to Professor Krishna sir, having a wonderful. Again, congratulations to the team of Media Technology and Applied Immunology Chapter, Dr. Neeraj Gupta, Naren Reddy, and Dinesh, all of them doing an excellent job for regarding all academic activities. I think we are coming to other three sessions or remaining, and in which even academics, I am concluding my talk. I wish you all the best program and Neeraj Gupta and team for excellent activities. Again, today the faculties are super in enlightening the topic concerned to them. I think all the delegates or the participants who join the program will enlighten with their knowledge regarding to enlightening the anaphylaxis different aspects. And over to Sanjita Day for further proceedings. Thank you for this opportunity for the meeting. Over to the proceedings.
Thank you, Dr. Jose. I believe he was in a car from what I could make out. Only hope that he was not driving it also. So thank you, sir, for your kind words. Next, I invite Dr. Zahir Abbas to take his session on refractory anaphylaxis and biphasic reactions, risk factors and management. The talk is approximately 20 minutes. Dr. Zahir Abbas is a renowned allergist, and we are very grateful for his time here today. And if you could start your screen sharing, please, sir, and we could proceed with the next session.
Good evening.
Dr. Abbas, you're muted, sir. So to
No.
proceed with the next session.
Okay. Can you hear me, ma'am?
Yes, you can be heard loud and clear. So
Okay,
please,
thank you. So
you
at the
start screen
outset,
sharing. Please proceed.
I'm thankful to Indian Academy of Pediatric Allergy and Dr. Neeraj sir's team for giving me an opportunity to speak over this topic: refractory anaphylaxis and biphasic reaction, the risk factors and the management. So before I start with the main content of the topic, so I will directly just go through the definition of anaphylaxis. So it is a Greek word. Ana is against and phylaxis is a protection. So it is acute allergic multisystemic type 1 hypersensitivity reaction which involves skin, airway, vascular, and GI system. So the word was first time coined by the Dios, Portier, and Richet in 1901. So actual word was aphylaxis, and which was not sounding good. So the Dr. Richet made some correction and he made this word as anaphylaxis, and he was awarded with Nobel Prize in Physiology for his novel work for anaphylaxis in 1913. So looking at the history of going back, so first death from anaphylaxis which occurred during this 2641 BC. So the Pharaoh died after hornet sting. So this was the case. So we have this National Institute of Anaphylaxis, Allergy and Infectious Diseases and Food Allergy and Anaphylaxis Network definition. So by definition, it is nothing but a serious reaction that is rapid in onset and may cause death. So there are multiple mediators are responsible for this, as it is a multi-systemic reaction, and the multiple mediators are not just histamine. It could be prostaglandins, kinins, platelet activating factors, interleukins, and tumor necrosis factors are there. So leukotrienes are also there. So the reaction could be associated with shock or without shock as well. So quicker recognition is needed, as we know that in fact allergies may affect nearly 50 million people throughout the United States. If you look at this figure, if you look at the impact of the anaphylaxis in pediatric population by this which has been published in 2007. So 10.5% population is pediatric population is affected per lakh, and increasing over the past 4 decades. So 2:1 male is to female ratio is there, and 25% required admission. 40% children had a prior history of allergic reaction, and unfortunately, only 20% of the prior anaphylaxis patient had an EpiPen available during the repeat anaphylaxis encounter. If you see the picture of in USA, 1,500 deaths per year are there, and rate of anaphylaxis related hospitalization in 1919 was 21 per million, which rose to 25.1 per million. So this is the scenario. By now coming to the etiology of anaphylaxis, we better know. Tirumala sir has already covered, but I will just brush up through go through, rapidly through this slide. So pharmacological agents. So the first and the foremost thing is antibiotics. We are having this beta-lactam antibiotics. So those antibiotics which are having the beta-lactam ring in their chemical structure are called as beta-lactam antibiotics. So they include penicillin and this cephalosporin and carbapenems are there. NSAIDs, we know aspirin is there, and other NSAIDs are there. So far as the food items are concerned, we are having this fish, shellfish, peanut, tree nut, eggs, milk, and soy proteins are there. In insect stings, we are having this honeybees, wasp, yellow jackets, fire ants we are having. So in latex, we are having the balloons, hospital clothes, even condoms are there. So they are responsible for this, and IV contrast agents are life-threatening reactions. So these are the things. So causes and characteristics for anaphylaxis. So if you see at this, so the food are most culprit agent in children age group, in pediatric age group, and medication and iatrogenic causes are in the older ages, and insect venom sting, it can occur in all ages. Symptom or presentation wise, breathing problem will be in the food allergies, anaphylaxis, and circulation problems will be in medication and insect venom sting. So rapid onset, less rapid onset will be in the food proportion, this, and the medication and insect sting, there will be a rapid occurrence of the reaction will be there. So if we are having this in short, we are having the human anaphylaxis is categorized into immunological and non-immunological. And third one is whenever there is no cause, that is idiopathic. And we are having this term an anaphylactoid reaction, so that the clinical scenario will be same, but the presentation will be against the same, but it will not involve it will not be Ig mediated. So risk factors, coming to the risk factor for anaphylaxis, it is that there will be history of previous anaphylactic reaction in that individual, and whenever the individual is atopic, asthmatic, and the elderly population with comorbidities and medication. Cardiovascular diseases are again there, will be there. So medications, certain medications are there. The peoples will be on the certain beta blockers like propanolol, atenolol, metoprolol. These are the things. And AC inhibitors like ramipril, all the prils in this captopril, enalpril are there. And ARBs are all the sartan group will be there, will be responsible and may flare up the reaction or anaphylaxis in a psychiatric way whenever they are taking some monoamine oxidase inhibitors are there. So they can also give rise to this anaphylactic reaction. Now jumping to this directly on the reaction types of anaphylactic reaction, typically we are having this uniphasic anaphylactic reaction, biphasic anaphylaxis, and protected anaphylaxis. So one by one we will cover this. Uniphasic anaphylaxis reaction is nothing but you can see over here. So the antigen exposure where is there. So it is nothing but the isolated reaction producing signs and symptoms within minutes, typically within 30 minutes of exposure to an offending stimulus. So this is this uniphasic reaction. And biphasic reaction is a reaction that is the recurrence of anaphylaxis symptoms within 1 to 72 hours, and usually within 8 to 10 hours. So after initial resolution, without re-exposure to the allergen, the patient will have the symptoms. So you can see over here the first phase and the second phase. In between, the patient may be absolutely normal or asymptomatic for 8 to 12 hours. But this reaction can happen ranging from 1 hour to 72 hours, and mostly within the 10 hours. So after the initial attack and after the resolution of the first phase of the reaction. So that is typically biphasic anaphylaxis by definition. Now coming to the incidence of this biphasic reaction, it occurs in up to 20% of anaphylaxis cases. Most studies estimate that 1 to 20%, and it is often under-recognized as anaphylaxis. So what are the risk factors? So the first and the foremost thing, which is delayed epinephrine administration. So in the epinephrine, not instituting epinephrine in time may result into death, and this delayed epinephrine is a cause of this biphasic reaction as well. So severe initial reaction may be there, need for multiple doses of epinephrine. So incomplete the first resolution of the symptoms. Most of the time, though, there is the first phase is not resolved completely. There could be comorbidities, as I have spoken about the atopic individual or this asthma, and whenever there is a high dose of this aeroallergen is there, or oral rather than parental allergen exposure is there, so this can result into this reaction. Now coming to the delayed treatment, again this late epinephrine use, and whenever drug interference is there, I have spoken about beta blockers, AC inhibitors, alpha blockers are there, comorbidities, asthma, cardiovascular disease, and mastocytosis, massive allergen exposure, so venom or contrast or IV drugs, idiopathic, there is no clear-cut trigger or recurrent episodes will be there, and insufficient initial therapy. So underdosing, wrong route, or delayed fluids, or delayed this late epinephrine use. So the people try every sort of treatment except at the epinephrine, which we speak about that it should be given earlier, at the earliest in the lateral aspect of the IM. But the people try each and everything, every sort of treatment except this. This is the agony of this anaphylactic treatment. Now coming to the symptomatology of anaphylaxis. So we know that it is a multi-systemic thing, and due to the multi-mediator release in the circulation. So first and the foremost thing, skin, there will be high swelling, warmth, and redness will be there. And after that, this coughing, wheezing, and shortness of breath, these symptoms will be there. So as per one study, so they conducted studies, and we had some we respiratory people had a tug of war with our skin fellows or dermatologist friends. So they were most of the time they were at 73% at number 2, and most of the time we were at number 1 symptom wise at number 1 position with 74% of the these were the symptoms reported by the anaphylactic patient. Now coming to the nausea, vomiting, stomach pain, we are having this gastrointestinal symptoms, cardiovascular dizziness, weak pulse, fainting, shock, and loss of consciousness will be there. So these things will happen, and due to this fainting attack, the patient will fall down. So we had one colleague, he is the renowned allergist of India, and he had this bedbug bite, and he fell down when we were studying at the renowned Institute of India, and fortunately he survived, and he was given this adrenaline. Neurological, we are having this anxiety and feeling. So what is the proposed mechanism of this biphasic reaction? So the ongoing release of inflammatory mediators, which we have seen, this platelet activating factors, prostaglandins, kinins, and all these things, tumor necrosis factors. So there is an ongoing release of inflammatory mediator, and secondary wave of mediator release from the mast cell or basophil will be there. Most of the time the residual allergen or absorption allergen absorption happen. So whenever we suspect this allergen, the person should be freed from this inciting allergen. So because this residual allergen may produce biphasic reaction. Now coming to several retrospective case series and prospective cohort study have reported that delayed adrenaline administration is associated with a higher rate of biphasic anaphylaxis. So supporting the emphasis on early adrenaline use. And to back up my whatever I have said in the last slide, I'm having the guidelines which clearly position epinephrine as first line of therapy. So this WHO guideline, we know this, that it places epinephrine, and it says that it has a primary role in the management of anaphylaxis. We are having anaphylaxis practice parameter guideline, which will again speak out the same thing. We are having this NIAID. So epinephrine is the first line of treatment in all cases of anaphylaxis. ICON, we are having this international consensus on food allergy. So epinephrine is the first line of treatment for anaphylaxis. So one study has happened, and that speaks about these children with anaphylaxis who received this epinephrine. They required less hospitalization or even the less ICU admission. So 44% of the children with anaphylaxis received epinephrine before visiting the emergency department. So there was no difference in admission to the hospital and ward. So children who use epinephrine were less likely to receive antihistaminic as well. So what happened whenever the person comes to us, or a family physician or a physician, so they start from giving antihistaminic, corticosteroids, and all these things. But as per guidelines, we know they are the second line of treatment. Now coming to the refractory anaphylaxis is there. So refractory anaphylaxis is typically defined as persistent or worsening of symptoms of anaphylaxis despite of 2 appropriate doses of intramuscular epinephrine. So if the person is adult, we are giving 0.5 ml IM in anterolateral aspect of the thigh. So but if in spite of giving 2 doses, if the patient is not responding, that is called as a refractory anaphylaxis, and it is nothing but a critical and enduring and anaphylactic response that failed to show improvement despite of receiving initial epinephrine treatment. So this condition is marked by necessity for continuous intervention, and it may affect the various organ system even following several epinephrine. So I have gone through this slide. So it is nothing but the Resuscitation Council UK guideline. So that in short mention, whenever there is no ABC problem and whenever there is only mild localized skin symptoms, swelling or itching is there, it is not anaphylaxis. Whenever the generalized skin reaction, itching, pruritus, or this urticarial rashes is associated with ABC problem, problem, it is anaphylaxis. When ABC problem is plus skin symptoms are there, the guidelines say that it is severe anaphylactic reaction. Now coming to the treatment of this two entities or anaphylaxis as a whole. So first and the foremost thing is that we should focus on first aid. So whenever the patient is there, try to place the patient in Trendelberg position, or the patient is asked to lie flat on the surface, because or even the patient can sit also, because it will ease the respiration and the patient will feel better. But the patient is not allowed to stand, why I will tell in the next slide. Then after, whenever there is a insect sting bite or there, we have to place a tourniquet above the site of reaction. And after that, this ABC is there, this we have to maintain airway and oxygen, or all these things. So I'm talking about this first aid. So the WHO, World Allergy Organization, and this American Academy of Allergy, Asthma and Immunology, so they have come up with some pocket cards, and this anaphylaxis awareness things are there. So these charts have been developed by this American Academy of Allergy, Asthma and Immunology, that speaks about how to recognize the symptoms, earlier recognition of the symptoms for the common public or common, and for the family physician and physician, and how to know the and avoid the triggers. And it speaks about emergency action plan as well. So it speaks about carry self-injectable epinephrine at all times, and it can be how it should be taken. And these guidelines, the card speaks about this, the what are the different symptoms of anaphylaxis. So this is the thing, it is accompanied with the anaphylaxis emergency action plan. So everything is there. So, and the dosage has been also given in this chart. Now, coming to the treatment of this refractory anaphylaxis, there is an algorithm which is developed by this UK guideline, this resuscitation guideline developed by UK. So step-by-step management of refractory anaphylaxis is there. So first and foremost thing, we have already given the 2 doses of injectable or IM adrenaline, but the patient is not responding. So immediately call for help, or activate the code, or transfer the patient in the ICU, or call the expert and escalated the advanced life support team immediately. Now, after that, administer IV epinephrine. So whenever we are using this IV epinephrine, because why we know don't give. So and whenever we are trying IV epinephrine, it should be given in a specialized setting. Whenever there is a facility of ECG is there, monitors are there, blood pressure monitoring should happen in that ICU, and it should be given in the ICU setup. So start IV infusion. So the simple thing is that, so 1 mg per ml in epinephrine ampoule is there, and that should be instituted in the 100 ml normal saline. So it can be given with in a titrated dose, and continuous cardiac and BP monitoring is very essential, because this may result in arrhythmia if given and IV directly. Here we are instituting, or we are giving through the normal saline in 100 ml normal saline. It should not be given as a bolus epinephrine unless and until there is a cardiac arrest or expert supervision or expert setting is there. So next thing is that aggressive IV fluid is there, and resuscitation. So we have already seen that the anaphylaxis may be associated with shock, or it could be associated without shock. So the anaphylaxis with shock, so should be given larger volume of crystalloids. So this normal saline or ringer lactate solution we can give. So this can be given 10 ml per kg in the children per bolus. So this it can be repeated as well. So this will take care of this hypotension or shock. And then at second line of vasopressors are there. If the patient, if the hypotension is there and the patient is not responding, so we can try definitely norepinephrine, or vasopressin is there, or dopamine is also there. We are having this glucagon can be given. So this glucagon is there if the patient is on beta blocker, and if the patient is not responding to IM this IV epinephrine, also IV adrenaline. So and it can be given in 1 to 2 mg or 1 to 5 mg IV over 5 minutes. So this it can improve the cardiac output and bypass beta receptor blockade. Now coming to this adjunctive medication. So whatever we are giving, these are not substitute for epinephrine. Whatever we have spoken about this vasopressin, norepinephrine, dopamine, and glucagon. So these are not, most of the time the patient is having bradycardia. We have to give this atropine, glucagon, atropine, and all these things, vasopressin. We can give, but these are not the substitute for epinephrine, but may help the patient to stabilize. Next and thing is the patient, the people they give antihistaminic. So we are having this H1 and H2 receptor antihistaminics are there. So first generation and second generation, so diphenhydramine and ranitidine. So it will take care of this, the whatever the reactions, cutaneous reactions are there. It will relieve the cutaneous reaction, and corticosteroids can be given. Here hydrocortisone has been mentioned. Methylprednisolone can also be given in a proper dose. But it is having some role in this protected or biphasic reaction, may have this role, may reduce the risk of biphasic reaction, not useful in acute or as a first line of treatment. Nebulized beta-2 agonists like salbutamol, ipratropium can also be given because it will relieve the bronchospasm. Now, first and foremost thing is airway management, which I have seen, but prepare the patient for early intubation, because once the laryngeal edema sets in, the patient, there will be very difficult in intubating the patient, and the stridor will be there, respiratory failure will be there. So it should be avoided, the delay should be avoided, and the rapid sequence intubation should be attempted at the earliest. And we can consider for cricothyrotomy as well. Now, continuous monitor, I have spoken about, it needs ICU care, ECG setting, oxygen saturation, blood pressure, urine output, and all these things should be there. And we have to watch for this biphasic anaphylactic reaction, because it can occur up to 72 hours or later. So observe the patient for 6 to 24 hours. Now, sorry. Once again, there is we are concerned about this skin and mucosal changes are there, because 10 to 20% of the cases it occurs in anaphylactic reaction. So correct posturing. So I have spoken about the patient is allowed to lie down flat with or without the leg is elevated. Here you can see this UK guideline. So the patient can be seen here with leg elevation or a sitting position. But the patient at any cost should not be allowed to stand supine, because it may have this cardiovascular collapse and death. So it has happened. Intramuscular IM adrenaline, we have spin, and so this is the thing. Here the patient is lying down flat or sitting, and he should not be allowed to stand, because the cardiovascular collapse is seen in 88% of the cases of this anaphylactic reaction. So this is the very beautiful guidelines which by UK, this resuscitation council. So we have seen this. So remove the trigger factor, ask the patient to lie down or Trendelenburg position, elevate the leg, and establish the airway, give high flow oxygen, apply monitoring pulse oximetry and ECG, repeat this adrenaline IM. But and if the patient and the dosage has been given, it is for intramuscular. But if not, the patient is not responding to this IM, 2 doses of IM, then this follow the refractory anaphylaxis algorithm, which is there 2 slides after that. So a refractory anaphylaxis algorithm is provided. IV adrenaline infusion in the form the basis treatment of the refractory anaphylaxis. Seek the urgent expert help to establish low dose IV adrenaline. So IV adrenaline should be given only by experienced specialists in an appropriate setting. So this is the refractory anaphylaxis algorithm. We again say that establish a dedicated peripheral IV intravenous or intraosseous access should be there. 6 expert help. Start adrenaline infusion. Again, the same thing is there. 1 mg per ml ampule is there. That is available in Indian market, Indian setting. So that should be mixed in 100 ml of normal saline. And per kg dose is for children and adult is 0.5 ml to 1 ml per kg per hour. So it should be given whenever we are infusing. The BP cuff should not be applied on the same thing where the infusion is going out, or another infusion should not be given through that line. So when there is an increase in BP, so it is likely to indicate that the adrenaline overdose is happening. And that's why we are giving this in ICU setting or specialized setting, because we can monitor all these things or arrhythmias as well. So we are concerned about this airways as well, where these guidelines speak about nebulized adrenaline, and whenever there is total airway obstruction is there, the expert help is needed, or we have to intubate the patient, that is rapid sequence intubation is there, or cricothyrotomy, this guideline speaks about. But I have seen this, and I have attempted this. This is called as airway adjunct. So this is nothing but the laryngeal mask airway. So it is simply, it can be held like a pen. So whenever, but it is not a substitute for this rapid sequence intubation or endotracheal tube intubation. So by the time you are for time being, it can be attempted. So because and whatever you have to attempt, because failure to administer this epinephrine will result in death. We know this. So, and whenever we are attempting this intubation or LMA, so this should be attempted at the earliest, because once the laryngeal edema sets in, so it will not, there will be bleeding, and the tube will not go inside. So the epinephrine will take care of this thing as well. So vasopressive effect of epinephrine, along with its effect in preventing and relieving the laryngeal edema and bronchoconstriction, will be life-saving. So this is the LMA. Now, antihistaminic we have seen, corticosteroid we have seen. So why the patient is not allowed to stand from lying down positions, supine to standing are associated with cardiovascular collapse and the death during anaphylaxis, due to as there will be reduction in venous return to the heart, and the consequent reduction in the myocardial filling and perfusion will be there. So it is important to remain flat with or without legs raised to maximum the venous return. So in cases where the symptoms are predominantly affect the airway or breathing, the patient may prefer semi-recumbent or sitting position, because it will be easier to breathe in and out for the patient. Now, what is the difference between this biphasic anaphylaxis and the refractory anaphylaxis? So, biphasic, we know, we have seen the symptoms return after a resolution. In first phase will resolve, the symptom will also resolve, and after 8 to 10 hours or a gap, the symptoms will again occur. This is biphasic reaction. So refractory anaphylaxis symptoms will persist despite of treatment, and the patient will not respond to the adrenaline. Initial improvement will be there in a biphasic anaphylaxis. Little or no response will be in refractory anaphylaxis. So these are the things. Again, the same thing to revise this IV epinephrine infusion action plan. Start aggressive IV fluid resuscitation. Vasopressor we have seen. Give glucagon if the patient is on beta blocker. Adjuncts we are having this antihistaminic, but these are not, definitely not the first line of treatment in anaphylaxis. Secure the airway. I have spoken about this LMA and the intubation, rapid sequence intubation, and admit the patient ICU with full monitoring. Again, the same thing that is the for management of refractory anaphylaxis, which the guidelines spoke about, norepinephrine and vasopressin, glucagon. All these things are there. And secure the. So last chart is there. The physicians or clinicians are confused. So what is the difference between this protracted anaphylaxis? We have seen biphasic reaction and protracted anaphylaxis, refractory anaphylaxis. So what is this protracted anaphylaxis? So this is the third thing. So anaphylaxis that may persist for hours together. So initially the patient will respond here in protracted anaphylaxis, but here in refractory anaphylaxis, in spite of 2 doses, the patient will fail to respond. And protracted anaphylaxis may last for more than 24 hours. And here refractory anaphylaxis will be ineffective even after multiple doses. So supportive care ICU monitoring, here the escalated therapy, vasopressor, intubation, ICU is must for refractory anaphylaxis. So severe and partially controllable severity, here life-threatening reaction and thing is there with the refractory anaphylaxis. So persistent bronchospasm despite of steroid and antihistamine. Hypotension is not resolving with epinephrine and fluid. So with this, I thank you all for your patient hearing. And once again, I'm thankful to Dr. Neeraj Gupta sir, Dr. Danesh sir, and Dr. Tirumala sir, and Dr. Sitesh Roy sir for giving me an opportunity to speak for this topic and the biphasic reaction and refractory anaphylaxis. Thank you for your patient hearing.
Thank you, Dr. Abbas, for your rendering of this very difficult topic. I have one question. No, I think Dr. Gupta is congratulating you. That's in the chat box. I have one question for Dr. Abbas, if he is still there. Otherwise, we'll come do it at the end of the talk. So next on, we have another session that is going to be moderated by Dr. Sitesh Roy. He's a US board certified allergist and clinical immunologist, and he is with us today. And are you here, sir? So
I am here, Dr. Sanjukta. Thank you very much.
is Dr. Sitesh here?
Can you all hear me? Hello, I'm here.
Hello. Yeah, okay. Thank you, sir. I think you are on for the next session. So if you could start screen sharing with us, please.
I think the previous speaker would need to end the screen sharing, then I'll be able to do
Dr. Abbas, if you can stop screen sharing for now.
Yes, ma'am.
And we will have the questions at the end. Please stay with us till the end.
Yes, ma'am.
Then we can have a good discussion, interaction at the end. Dr. Sitesh Roy, he is a US board certified allergist and clinical immunologist, and he is based in Mumbai. And if you could start screen sharing, please.
Are you all able to see my screen?
Yes, sir.
Okay.
Yes.
All right.
Yes.
So thank you very much to the IAP pediatric chapter
Yes.
and to the entire team. Gives me great pleasure to be speaking on this topic. Clearly, I have been following a few of the lectures in the last 2 sessions over 2 days, this being the third and final day. A lot of very interesting topics. And what I'll be covering today is the prevention of anaphylaxis, which I know that each of the speakers who has spoken on separate topics has also covered, and a little bit on how patient empowerment, action plans, auto-injectors, and desensitizations make lives easier for people who have this very severe episode happening. So I think the definition is very clear. Most of the patient advocacy groups wanted the inclusion that anaphylaxis can progress rapidly and cause death. This was something that we as doctors were not including in the previous definitions, but it was actually the patients and parents who said that it must be there. And hence I highlight that in terms of the risk. We don't have exact data for India, but the prevalence, lifetime prevalence is somewhere between 1.6 to 5%, which is a very high number when you think about it. And we clearly know the common causes. Triggers have been discussed multiple times through the different presentations, but foods remain at the top: insect stings, drugs, latex, exercise, blood and blood products, what used to be called pseudo-allergic reactions, now called non-immunologic reactions, and literally anything else. And when you look at the list, even things like seminal fluid giving rise to anaphylaxis after physical intercourse, vaccines, components, the list is very, very long. And at the end, we have something called idiopathic anaphylaxis, which also I shall briefly speak about. I think beyond any doubt, what remains as the cornerstone of management of anaphylaxis is epinephrine or adrenaline. Epinephrine in the US, adrenaline in the UK and India, it's the same thing. And we are well aware of the dosages. I won't go through that again, but as we know, the commonly available ones are at 0.15 and 0.3 milligrams. The injection is usually given in a mid-outer thigh, but can also be given in the deltoid muscle. But it needs to be intramuscular, as we very well know. In the US, in the Europe, there is a third dose that is available, and this is just an example of all the other options, and this is not every single option. There are even more options that are there. But as we know, EpiPens, Adrenaclick, Jex, none of these are available in India. What we have in India is the vials, which you see on the right corner, and you sometimes have the multi-dose vials. And that's what we have to really empower the patients with, because for them to know that they have something that can save their lives is probably the most important thing. The sad part is many a times they're given these things, but not told when and how to use it. Or even if they're told when and how to use it, the fear that they have in their minds of using this is sometimes not addressed. And hence it becomes extremely important that when you are prescribing epinephrine, and I see this almost every week in my practice, someone coming in who's been given adrenaline, but not told how to either load the syringe or where to give the injection, or even if they have been told, they were so overwhelmed by the fact that they could lose their lives due to this disease that they don't remember anything, and hence written instructions become extremely important. This is just two examples where, as you can see with adrenaline, there is a gray cap labeled 1 and a gray cap labeled 2 that has to be removed, whereas in EpiPen, as we know, there's only one cap that has to be removed and you're able to directly inject. And hence it's important for us as treating physicians to also know these different devices, ideally have demonstration devices available in our practice that we can actually show patients and let them try it on themselves, because that is the smartest and best way for them to be able to use it when they need it. Otherwise, they will not be able to use it. So, some precautions, obviously we carry all the medications. We have to prepare what is called an anaphylaxis kit for these patients, whether they are kids that the parents and the school and all the other caretakers have, or the adult has, along with emergency numbers. And you've seen several examples of emergency action plans, and I'll show you some more. But it's very, very important that epinephrine is not shared with anyone else unless you're 100% sure that they're having an anaphylactic reaction. And unfortunately, there have been people who've had cardiac issues or a stroke or something else that was misidentified due to some overlapping symptoms, and they were given epinephrine that didn't belong to them and actually ended up having a bad outcome. So something that we tell our patients and parents, if they are kids, that do not share epinephrine with anyone ever. You've heard about all the supportive treatments. I'm not going to go into this. The general trend, and this is very, very important, I want to point it out. We always have heard diphenhydramine, chlorpheniramine, all these other sedating antihistamines. During an anaphylactic episode, you do not want a patient to use a sedating antihistamine. You don't want them to get drowsy, where you can't figure out whether they are having hypotension or they are going into anaphylactic shock, or they're actually drowsy because they took a medicine. And hence the newer guidelines are all suggesting using second generation antihistamines as much as possible. Wherever the emergency department or the clinic or hospital that the patient gets first treated, it's extremely important that they have an observation period. Again, something that I find is lacking in many places, not just in India, even in US, we used to see where people were discharged in an hour after they got stabilized from anaphylaxis. And hence this whole concept of at least 4 to 6 hours observation after stabilization is very important. Giving them epinephrine at discharge from the emergency room, this really empowers them and gives them the confidence if they are given the right instructions on when and how to use it. And then very, very important, referral to an allergist, immunologist for further exact pinpoint diagnosis and treatment, as well as prevention, which we shall talk about. When you look at fatal anaphylaxis, we've heard about the delay or failure of use epinephrine. Rapid onset anaphylaxis generally tends to be more severe. Past history of anaphylaxis clearly makes the person have a greater risk of future reactions. An older age, atopy, uncontrolled asthma, COPD, cardiovascular disease, not having urticaria angioedema, which makes it hard to recognize. And the reason why I point this out in prevention is you have to study the patient's pattern of how they presented more than once. And if they have these risk factors, you have to take extra time, extra caution, and extra attention on how to guide them to recognize what is happening with them. You've heard about the drugs, mastocytosis in other lectures also. I won't go too much into it. One thing to remember very strongly is risky behavior. And this is a huge problem with adolescents sometimes with children also, and sometimes with some adults. I know patients who have shellfish allergy who would pop in 3 Allegras and still go out and eat shrimp sushi, which is the classic example of risky behavior, carrying their EpiPen with them. But they are not willing to quit some of their habits. And this is something that requires immense amount of counseling, guidance, a lot of behavioral therapies sometimes, but recognizing that this can mean a life-threatening episode and even death. When we talk about preventing anaphylaxis, avoiding the specific trigger, and I'll go through the foods, I'll go through the venoms, I'll go through the other triggers in subsequent part of the talk. But as a general rule, you want to specifically identify the trigger and avoid it. You want to manage comorbid conditions, especially asthma, cardiovascular disease, if there's any mastocytosis, or mast cell activation syndromes. You want to make sure that if there are beta blockers, they are converted into highly selective beta blockers or other drugs if they need to be used so that they don't interfere with the therapy. Young children not being able to recognize the symptoms or report them, parents can teach and train. I've had 2 and 3-year-olds very confidently and clearly tell their parents when they're having an allergic reaction. So this is a matter of training and education. And then, as I said, adolescents and young adults having risky behavior with regards to food avoidance, poor compliance. There's a lot of bullying. There's the other things that go on, and that becomes very, very important to also address. Reading labels, learning to avoid the food triggers till a more definitive treatment is available. Caution about eating in public places, difficulty with regards to a lot of food labeling issues, which is decently good abroad, challenging here, getting better with time. Very specific testing so that we can identify the cross reactivities and know which ones are real, which are not. And then immunotherapy, which becomes very, very important. We know primary prevention of food-induced anaphylaxis was very much possible through the LEAP study, where early introduction of peanut between the ages of 4 and 11 did help several of these patients go into a situation where they have negative tests and did not have any reactions later compared to the group that was still practicing peanut avoidance, though they were in the high-risk category. Double checking food ingredients, making sure you ask a lot of questions. If you don't get the answers on the food preparation, then not consuming that food and recognizing when to say no and not come under pressure. These are things that actually children, teenagers, and adults require training on and guidance on. Because through a career of about 25 years of treating both kids and adults, day in and day out, I've seen many people who have under what I would call emotional pressure consumed foods that they did not feel right about and ended up paying a very heavy price. When you're talking about a child who has had a severe allergy to one food, being careful about introducing one food at a time, preferably 3 to 5 days before you introduce a next one, and also making sure that you're providing them the best possible care for their atopic dermatitis and keeping their skin barrier optimally controlled, because that's where a lot of the sensitization occurs from, which then ends up causing problems, if not only in testing, but also in reactions. Cross-contamination of foods, a huge issue that both patients, their families need a good understanding about, especially when eating in public places, restaurants, common areas. But there are a lot of things that can be done. This is just one example of what can be done to prevent cross-contact of food. Sharing of food utensils, common preparation, many things are there, cleaning counters. I'm not going to go through every single one of them, but this cross-contamination is something for the most highly allergic patients can mean the difference between having a healthy, normal meal or ending up in the hospital or in the ICU. These kind of what I would call informative recognize and respond to anaphylaxis posters are something that are available from multiple organizations around the world, and where people are actually able to identify what the symptoms are, recognizing that now Most of the anaphylaxis guidelines say that it may be a single system involvement, where we used to say you need two systems involved. It may be only cardiovascular, it may be only GI and still be anaphylaxis. And being able to then inject the epinephrine as the first and primary choice and call the nearest emergency medical services, while antihistamines, bronchodilators, steroids, whatever else the person may have in their anaphylaxis kit, if available, becomes very important. When we talk about foods, oral desensitization versus tolerance induction becomes very, very important. Desensitization is where you raise the threshold at which the individual has a reaction, but you don't completely induce oral tolerance, where they can go without ongoing treatment and be able to consume that food at free will with gaps and interruptions, whereas in oral desensitizations, you would need ongoing ingestion of the food on a regular basis so that the desensitized state is maintained. So this is a very important thing, especially when we are having discussions, because the decision to start food oral immunotherapy is a very, very big one for both families and the treating physicians, because the type of food allergens, the presence of any uncontrolled asthma, pregnancy, malignancy, impact of food allergy on quality of life, burden, experience of food allergy, history of anaphylaxis, eating behavior, social behavior, risk of future accidental exposure, ability to treat the reactions, very, very important. Patient and parents' wishes, expectations, and motivation, expected benefits, acceptance of aims, risk constraints, the risk part being extremely important, and hence a documented decision-making and a signed informed consent, because whenever you do these and you're doing it for severe allergies, you are potentially taking the risk of a life-threatening reaction and even potentially a death. And that is something that needs to be conveyed very clearly and with all the precautions and with all the sensitivity to the family or to whom you're counseling, that everything will be done to prevent it. Now, non-anaphylactic peanut allergy also, when desensitization is done, you can see that there is a significant reduction in what I would call a remission that is seen, especially in young children who have a low baseline peanut-specific IgE. It is possible to have an intervention group with almost 69% reduction, where oral immunotherapy led to desensitization and eventually even remission. And when you talk about the standard protocol for food allergen immunotherapy with peanut, for example, this is a long process. As you can see, to reach maintenance dose, it would take about 9 months. And beyond that, the therapy would go on for much longer, on an average 2 years. Maintenance dose can sometimes continue for a lifetime if you're not able to completely desensitize. This is where, again, a part of the discussion that needs to be had with parents or with the patient very, very carefully, because they need to have a realistic understanding of what they are looking at. Many a times, if you just tell them, that, okay, after this, your risk will go down, you'll be able to consume it, they assume that they will have it when they want. But no, they need to consume it on a regular basis, especially if they are only reaching desensitization and not oral tolerance induction. We know that there are products like Palforzia in the US, not here. It was approved by US FDA in 2020, where you can elevate the dose at which potentially peanut may cause a reaction to an individual, and hence the fear that the family lives in or the patient lives in, the anxiety, the stress, the unknown risks that are associated with it can be tapered and tailored. That's the whole idea of food oral immunotherapy and desensitization that we are talking about. When we talk of anaphylaxis to medications, I know you'll have had entire lectures on these, but we clearly have the penicillins and antibiotics and the non-steroidal drugs, followed by biologics, monoclonals. Obviously, the anesthetic agents, many other drugs are there. Pretty much any drug can potentially cause anaphylaxis, and we should never ever forget that. The accurate determination of the offending medication, we already heard an excellent presentation by Dr. Krishna, and how you literally have to be a detective and go very carefully with a timeline, looking at what happened when and what triggered what, to achieve the point where you can then do skin testing by prick and intradermal, and potentially even offer if the risk is not very high, oral challenges and graded dose challenges, and eventually even desensitization if there is no alternative. If there is an alternative medication available, that is always and always your first choice. You heard about these medical alert bracelets. These are important for food allergic patients. These are important for medication allergic patients. These are some examples of what they look like. They can be very simple rubber bands. They can also be very fancy metallic bands, as you can see. But the point being that if a person gets an exposure, gets a sting, is not able to tell anyone, this band could mean the difference between life and death for that person. Just briefly, I have put 2 desensitization protocols on. There are many, many, many options and ways of doing this, but this is an example of an oral and an IV penicillin desensitization. I'm not going to go through. There are over thousands of these for different drugs, which are available and accessible through different publications. Sometimes they are only case series because they are not huge studies, but they're still very beneficial when you have a case like that. When you think about insect sting allergies, anaphylaxis to insects are not uncommon. Knowing the behavior of the insect can help you actually avoid their home areas if a person is allergic. So educating a patient who has venom allergy about where they are likely to come in contact or interact with these insects is just as important as giving them an anaphylaxis emergency plan. For example, wasps, yellow jackets, hornets are scavengers, and they will like wherever there is food, there are drinks people have kept, they are open, Diet Coke or Pepsi can open, and the wasp has entered inside. And when they took the next sip, they've got a direct intramucosal injection of the venom, which has given them a very, very rapid and very, very severe reaction. So little things like that, when you counsel them, when you're going out, don't wear very bright clothes. And I think I've put that on the next slide, or maybe the one after that right here. Wear light colored clothing, not bright clothes that make you look like a flower. Don't wear perfumes or scented creams that make you smell like a flower, because then the insect will be attracted towards you. Wear clothing that covers you, and if the insects come around, take precautions and be calm. Because if you react and start flicking them around, they will come and bite you more, especially maybe not so much the honeybee, but the other guys are pretty aggressive insects, wasps, wasps, yellow jackets, and hornets. They react to your reaction. And again, very, very good subcutaneous venom immunotherapy is available. I'm sure you've heard about that in the previous lectures. Again, these patients can also wear a medical ID tag or a medical alert bracelet. Some examples of the protocols that are used for desensitization to different venoms. Again, there are rush protocols, there are cluster protocols, and then there are standard protocols. I do a lot of rush protocols in my practice here in Mumbai because patients come to me from far and wide. They stay with us for a week or so, and we try to do cluster or rush with them, get them out of there within a couple of days at their maintenance dose. And sometimes I've even had to choose a dose lower than maintenance for the first year, but in the second and third year, I've been able to push them up to the full dose. And these are very, very satisfying cases because these individuals land up in the ICU, sometimes on a ventilator. And when they actually get this immunotherapy, it gives them an immense amount of confidence in living their life, which cannot be described in words. You have seen these before, but there are many good emergency action plans, and every single patient with anaphylaxis should have something like this. Not everyone can understand a complex plan. So sometimes your plans have to be very simplistic, very basic. If you have these symptoms, this is what you do. If you have these symptoms, this is what you do. If you have this symptom, you take your epinephrine. If the person educated, intelligent, can understand, read, you have to go through this entire plan with them line by line, or your nurse has to do that, whom you train. Many of these plans have a photograph, especially if it's a child going to school or other places for training or whatever. And every step of what needs to be done is mentioned, which has been covered by the other speakers before. I'm not going to go through them. And one thing that I present on this slide is having a language sensitivity. So if you give an English plan to a person who has 5th or 6th grade English reading capability, they're not going to find that plan to be very useful. Whereas if you give them in their local language, and if you don't have it in your local language, convert it into your local language and try to give it to them in that, they will really thank you and bless you, because they will understand what you're saying and they will know what to do when, and their lives will be saved, or their family members' lives will be saved. These are some things for healthcare professionals who are managing and need to know what the different criteria are for anaphylaxis and when to give the intramuscular epinephrine, what to look at in the different organs, all of them coming to the same purpose of providing a simplistic standardized protocol or care plan that the person or the doctor can use. Xolair, which is omalizumab, has been one of the new additions, as we know, for multiple severe food allergies. It has now been approved by the US FDA last year for use in terms of reducing the threshold at which a person may have a reaction again. It also gives the opportunity to do food oral allergen immunotherapy in a more safer way if this is on board before the desensitization is started, recognizing that in clinical trials, 17% people did not have meaningful improvement. So don't assume because you're giving this, the person is safe. You still need to have every other bit of the plan in place that I mentioned. I think you'll have had an entire talk on exercise-induced anaphylaxis, but talking about the prevention part, other than the counseling that you would do that don't eat the food and exercise within 4 to 6 hours, I think the cofactors or the co-triggers, like not having non-steroidal anti-inflammatory drugs or doing the exercise when a woman or a girl is on their monthly cycles, or alcohol or heavy pollen exposure in a sensitized individual. These things can occur very, very simplistically. The person may forget and they need reminders, and being able to guide them very specifically with written instructions can make all the difference to their health. Alpha-gal syndrome, I'm not going to go too much into it, but again, something that's very interesting. And as you see on the 4th point here, a typical presentation is a patient waking up in the middle of the night, collapsing on the way to the bathroom after having ingested mammalian meat products for dinner, where the episodes are even sporadic. So these can be very challenging to manage sometimes before they can even call anyone for help. Also in the exercise-induced anaphylaxis, having a partner with you while exercising is something that can be very, very beneficial in prevention. Besides all the other things that you all have already heard or I have just covered. Idiopathic anaphylaxis, again, a very challenging issue where all other investigations come up negative. Serum tryptase levels can help. Mast cell activation can be seen. There are other mast cell mediators like N-methyl histamine, leukotriene E4, prostaglandin F2, alpha. All of these, when identified, there are therapies. So if the urinary metabolite prostaglandin F2 alpha is raised, treatment with aspirin twice a day can be protective for these patients, where we normally think NSAIDs are bad in some of these cases. Here, it's actually a therapy. And then these patients require a higher dose of prednisolone over 1 to 2 weeks, and then a tapering course over several months, which can actually reduce what I would call the threshold of their idiopathic anaphylaxis. And omalizumab has also been beneficial in some of these patients. Again, they all have to carry their emergency action plans, kits, epinephrine, antihistamine, steroids, inhalers. So, this is a very brief presentation of something that's actually a very big topic and probably 4 lectures combined into 20 minutes. But given the high prevalence and realization that physicians of all specialties, right from general practitioners to super specialists, are going to be faced with this, making ourselves aware, spreading the word, looking at consensus guidelines. Because remember, it's very few of the drugs used in management of anaphylaxis are actually studied in a double-blind placebo-controlled trial. They are all by consensus and expert opinion that they are mentioned into the places that they are. Careful history, measurement of the mediators, prevention is the key. Patient family education, public awareness. There are lots of programs that we do in schools and other places. Epinephrine is your primary methodology of treatment and remains your primary mainstay. demonstrating it, showing it, reassessing it, checking when it's getting expired, teaching people to take care of it right, not leaving it at the dashboard of your car where it may reach 120°F and be completely destroyed and useless by the time you use it, protecting it, taking care of it, replacing it. There are many, many things that we have to empower these patients and their families with. But when done correctly, they really live a much more confident life, which is what the goal and purpose of this entire talk is. So, and successful desensitization therapies, whether it be to venom, whether it be to certain drugs, whether it be to food desensitizations, are now there. Omalizumab certainly can help with that process where rightly indicated. So thank you very much. And we can open up for some questions if there are any, and I turn it over back to Dr. Sanjukta.
Thank you, Dr. Roy, for a very comprehensive talk. We'll have to take the questions at the end because we are running short of time, and we have Dr. Shoibal Moitro to finish his talk in a very short span of time. I would also request Dr. Roy to please look the chat box, and if it's possible to answer some of the questions there, but we will discuss the questions at the end when we have time. So over to Dr. Shoibal Moitro. He is a very learned colleague, very prolific researcher, a great person to be around, and someone who will always teach you something new in allergy. Dr. Shoibal Moitro will be talking on, he was supposed to take the first talk, but he'll be talking on anaphylaxis in ENT and dental suites and radiology suites. So we are faced with this problem. I have had a very nasty experience of seeing someone going into an anaphylactic shock during a CT scan with contrast. So over to you, Dr. Shoibal Moitro, to tell us what to do in this situation. So you have started screen sharing. So Dr. Moitro, please, over to you.
Yeah, thank you, Dr. Dey. It's really a privilege to be in this webinar series. Is on anaphylaxis, organized by the Pediatric Allergy, Asthma, Immunology, a chapter of the IAP, and Dr. Neeraj being at the helm of the affairs. So, and it's really good to see Dr. Satish, Dr. Zahir, TK, and Evolve. Okay, so I think I won't take long because it's really quite late. So would like to touch upon the salient features which I want to be passed on to the viewers, because it's quite late, and then we can have a discussion. So the topic which is allotted to me is anaphylaxis in the ENT, dental, and radiology suites. So I don't have anything to declare with respect to this talk today's evening. It is very important that long back in 2006, that this triangle it's really catched my eyes and it stays with me. So whenever for any condition, and we need to assess the risk, reduce the risk, and educate for the long-term prevention. And for the immediate prevention, we need to recognize, treat, and prevent. This goes for the majority of the diseases. And when we talk in terms of the anaphylaxis is like illness, it goes same for here also. So that means in an acute setting, we need to recognize it, treat it, and also know how to prevent it. But in the long term, we need to assess the risk, reduce the risk, and educate the healthcare professionals and the patients and together. And this webinar, this kind of webinar goes a long way in actually fulfilling this aim of reducing the long-term fatalities because of anaphylaxis by educating the healthcare professionals. So I do not need to reiterate the things because this we have already know, but only just remember that it's a serious allergic reaction that is rapid in onset and may cause death and progress rapidly to cause death. As Dr. Roy was just mentioned, this is one of the important factors and tenets which has been included. So typically we know it's a multi-organ involvement, and there could be some scenarios like just in my next slide where these scenarios can occur. Like first scenario, it could be like the acute onset of an illness and with inadvertent and involvement of the skin and the mucous membrane, respiratory compromise, and the organ damage. Or maybe when two or more of the followings are there, like the skin involvement with respiratory compromise and the BP, like the shock and all, that is in-organ involvement. And when we know the allergen, then it is just leading to shock is also an anaphylaxis. There we do not need two-organ involvement. So this applies when we talk of the anaphylaxis in the dental ENT or the radiology suites, because we need to keep in mind and that all the scenarios can happen. So as TK has so elaborately said in the perioperative anaphylaxis, so it same goes because we know that what the procedures which happens in the ENT or the dental suites, this can lead on to the anaphylaxis as well. This is somewhat a busy slide, but I only want to highlight one or 2 points that there can be multiple pathways of the anaphylaxis. Like we can say that it is a type 1 IgE or a non-IgE mediated. It could be a cytokine release. It could be mixed with the mast cell and the T cell mediated, or it could be complement mediated. So when we talk about the medicines, okay, like the antibiotics or maybe any drugs, it could be either this type 1 or the non-IgE mediated. And when we talk of the contrast dyes, it could be a complement mediated. But very, very important thing to gather from this slide is whatever be the pathway, epinephrine is for all. Okay, so this is very important. So we do not bother about the pathways of the anaphylaxis. Whenever we have diagnosed anaphylaxis or suspect anaphylaxis, we should not waste any time in knowing the mechanisms. Just straight away give the adrenaline. Okay. Now this was an interesting article which was published in the JACI in Practice in 2017. Though it's not the Indian data, but it shows that anaphylaxis is on the rise. And of this is very important. The rate of the medication-related anaphylaxis increased by 212%. That's a huge, huge number. Now, why this increase is in anaphylaxis? Part of it could be because of more uniform, standardized diagnosis and once we know that is the WAO or the other bodies who have come up with the anaphylaxis definition, it became more and more well-defined. So people started suspecting it more. So that could be one of the reasons. Along with that, whether there is also a hidden true increase in the anaphylaxis is because of the rise in the allergy epidemic all over the world is also a thing we need to know of concern. This is actually the ED visits for the anaphylaxis between 2005 and 2014. It's the US and published in the JACI in Practice. So now, see, anaphylaxis can be triggered by many things. And Dr. Roy has just elaborated so many factors which can trigger an anaphylaxis. But one thing we should keep in mind that for the most common etiology for anaphylaxis in adults is drugs. Whether the drugs used in the perioperative settings, the drugs used in the ENT suites, in the dental suites, or maybe the radiology suites. So it could be in contrast agents, it could be dyes, it could be chemotherapeutic agents, anesthetics, NSAIDs, antibiotics. So in the adults, the drugs are the most common cause of the anaphylaxis. And this drug-induced anaphylaxis is more common we see with the hospitalized patients because they get lots of medications. And so that is one of the reasons. Now, when we tend to think of the ENT or the dental suites, now we need to understand and that what are the common medications which are used over there. So we know that local anesthetics is very commonly used in for the outpatient ENT and dental procedures. And so the most common is the amide local anesthetic and is the lignocaine that is being used. So now we know that the amide local anesthetic is the less common cause of the anaphylaxis, though there has been reports of the lignocaine causing anaphylaxis. Okay. But if you say that which is the most safe amide local anesthetic, then there are some reports that mepivacaine and maybe one of the safest alternative in the amide local anesthetic. But amide local anesthetic cause of anaphylaxis is less, much less than the ester local anesthetics. But the ester local anesthetics is not available in India, like the benzocaine for the use. Now, antibiotics, it remains one of the major cause of the anaphylaxis in the perioperative settings, and the ENT and the dental suites where to receive mainly the penicillins or any other antibiotics. Use of the natural rubber latex or the latex gloves is always has been a cause anaphylaxis, but with the reduction in the use of the latex gloves in the OPD suites, it's of the departments, there's a reduction in anaphylaxis to the latex. But it's always known that the patients with a spina bifida or uncontrolled asthma, allergy to elastoplast, or maybe banana, kiwi, avocados, they would increase risk of having anaphylaxis to the latex gloves. Now, in the what is the dental suites, all the chemicals that is used, there are more causes of the delayed hypersensitivity, but some can cause the immediate hypersensitivity and anaphylaxis. So it means a toothpaste containing the recaldent, it is one of the common agent used in the dental suites, and it has been shown to cause anaphylaxis, especially those who are allergic to milk. And iodoform containing endodontic products, as they are one of the causes of the anaphylaxis in the dental suites. Now, this chlorhexidine is very interesting because there has been a rise in the chlorhexidine-induced allergic reactions and the anaphylaxis, as if you see in the UK data and also data from the other countries, this chlorhexidine and induced allergic reactions, upstream reaction anaphylaxis is on the rise. Then definitely use of the sodium metabisulfite, Fischer sealants, and acrylates. All these are used in the dental suites, which are known to cause the anaphylaxis. Now, if we come to the radio contrast media or in actually the radiology suites, now gone are the days when we used the high osmolar contrast media. Now we use the low osmolar contrast media. So by and large, the low osmolar contrast media has far less chances of causing the hypersensitive reactions and anaphylaxis than the high osmolar contrast media. This is a very interesting and very good updated consensus statement, which was given by the American College of Radiology and the QuadAI. It is in the press to be published in the JACI in Practice. And so this is one of the most important things, updated things. So what was the main and actually the tenets of this consensus statement? First and foremost, it said that the anaphylaxis to low osmolar or ionated contrast media is much less than the previous high osmolar contrast media. Number one. Number two is when the index culprit ionated contrast media is known, then and there is initially the American College of Radiology, they said that it can be used with the pre-medications. And so mainly the pre-medications was the steroids and the H1 and the H2 antihistamines. There were several regimens of the steroids. Like one common is like the prednisolone 50 milligrams given at 13 hours, 7 hours, and 1 hour before the procedure, along with an H1 antihistamines and an H2 antihistamines at 1 hour before the procedure. But there has been good evidences which has shown that pre-medication does not reduce the anaphylaxis event. So now the recent consensus, this 2025 consensus statement, it says that those patients who had a mild reactions to the LOCM or the low osmolar contrast media, there is no need to give for any pre-medication. But rather than what is the way forward? So it could be that there could be a direct ionated contrast media switch. It could be in the low osmolar contrast media. That is, if one had the reaction to one of the agent, one can switch to another agent. So direct switch can be done. It has been shown that the direct switch helped in reduction in the hypersensitivity reaction to a much greater extent, rather than giving a medication. So this was one of the important tenet. Another is, if the patient had a very severe, like the anaphylaxis to the ideated contrast media, then the consensus statement says that either the patient should be taken for some other radiologic modalities. This may be where the contrast media this is not used, or if the patient has to undergo the same radiologic investigation, then there can be a direct switch into another contrast media with definitely a pre-medication. So this consensus, this is of the low quality evidence, but this is still holds good. Routine in giving the pre-medication is not there anymore. Another important tenet of this consensus statement is whether we should do a skin testing prior to giving any contrast media or not. But it is to be understood that this skin testing, whether it's a skin prick or the intradermal, they have the high negative predictive values, those like 70 to 80%, but there the positive predictive values are quite low. And 7% of the patients who had a negative reaction who had a negative test can have a reaction. So taking all these things into consideration, then very important is everybody should be well prepared. So whenever there is an anaphylaxis, suspicion of anaphylaxis, you needs to send a serum tryptase level within two hours of the symptom onset, and then we measure it with a baseline tryptase. This is the formula we give. It is 1.2 plus 2 nanograms per ml, or if it is more than and 20, we say that, well, it is definitely an anaphylaxis. There's a high specificity, but the sensitivity is low. So it supports the diagnosis of anaphylaxis positive, but obviously do not rule out if it is negative. So then we go for in the search of the culprit, which comes later. As various European guidelines test is that the skin testing and with the agent can be performed to identify the culprit agent. So usually they say that for the contrast media, it is the undiluted for the prick and 1 to 10 times diluted for the intradermal test. Very important to understand that these methods are not standardized, number one. And second is that there's lots of variability. So the QuadAI has not formulated a very good guideline for it, but we have guidelines for it under the IACI. So always, and there is an IgE, it indicates a sensitization, but it cannot be clinically a significant. So always it has to be correlated with the clinical history. I won't go into the management, and first we know immediately we suspect anaphylaxis, we give adrenaline. And if we repeat the dose every 5 minutes, we have detailed talk by Dr. Zahid about the biphasic anaphylaxis, the protracted anaphylaxis, the refractory anaphylaxis. Unfortunately, we do not have the adrenaline injector in our country. So it is basically the ampules in 1:1000. And so if it's a child of less than 6 years, as we give 0.15 ml, 6 to 12 years, we give 0.3 ml, and it is more than and 12 years we give 0.55 ml. But definitely to understand this transition and to lower dose or higher dose depends on the body weight. So it is saying that if a child crosses the 25 kg body weight, we can usually go to the 0.3 ml. And for adults more than 50 kg, it's a 0.5 or 5 ml. So one thing is very, very important to understand for all healthcare professionals, also walking in, that accidents are never planned. It comes suddenly. So emergency medication treatment plan must be immediately available. It should be accessible at all times. It's very important that in all the suites, the radiology, in the dental ENT suites, there should be the management plan should be available. So one important is the 3 hours anaphylaxis emergency action plan. Recognize, respond quickly, and review what caused the reaction. So first, to recognize and respond is very important to save the patient's life. These are the various anaphylaxis emergency plan. So this is one of the template which was given by a QuadAI, the anaphylaxis emergency action plan. One can actually modify it and use it in their own clinic or the hospital. But always remember that this emergency action plan include relevant allergens, symptoms, when and how to administer the adrenaline, where is the crash card, and calling for the emergency medical services in the hospital, and keep the patient in the supine position. Very, very important. So one needs to give the injection intramuscularly in the lateral aspect of the thigh muscles. And after it is being done, then one has to go to look out for the culprit agent by the same way in which how we look into the perioperative anaphylaxis. But it's very important to understand whenever is in doubt, inject epinephrine, because to err on injecting epinephrine is always better than to err on not giving an epinephrine, because we have seen that whatever may be the pathways, as epinephrine acts on all. And even if it is a vasovagal reaction or if it is a flushing reaction, anything, if one is given epinephrine, it does not harm. That's a myth. It's very important. So thank you very, very much. And I hope we can take some of the questions.
Thank you, Dr. Moitra, for wrapping up the talk as quickly as possible, because we were running short of time. Question to you and also to Dr. Zahir Abbas, who has spoken on anaphylaxis, is what do you think about auto-injectors not being available in India? Because the first response for anaphylaxis everywhere is give adrenaline, but auto-injectors is not widely available. So that's a very big deterrent. How do you deal with that?
Yes, so means yeah, Dr. This is very right. We all have been advocating that auto injectors should be available in our country, but we need to understand one very important tenet, important factor. We are India, okay? So with a huge population, and where the literacy rate is low, medical literacy rate is still lower, okay? So we need to understand that what everybody knows is that whenever in doubt, please rush to the nearest healthcare professionals. So maybe this is the only way out as of now. And so it's the more of a responsibility of all the healthcare professionals in whatever setting he or she is working to recognize anaphylaxis and give adrenaline. So that is a more of a responsibility of us increases much more, because the patients in wherever setting, whatever settings, had to rush to the nearest healthcare professionals, whether it's a clinic or it's a hospital or it's an ER or whatever it is. Maybe the availability of the adrenaline auto injector, whenever it becomes available in the future, to our patients, to help in empowering them to save their own lives. But then it will become the responsibility again for the healthcare professionals to empower them or educate them in the way how to use an AI. But as of now, we need to understand, because adrenaline is available in all the emergencies. So every clinic, every doctor in the clinic in OPD should have an adrenaline injections.
The next question also to Dr. Zahir Abbas. Yes, you wanted to comment on this, please, sir.
Yes,
Go
yes,
ahead.
ma'am. Yes, ma'am.
And
So sir has nicely mentioned about this use of this auto injector. You have asked about auto injector. So we are
Absolutely.
having our yes, we can use this simple tool of adrenaline is there, which contains the 1:2000 preparation is there. So we can feel it in the tuberculin syringe, and the only thing is that you have to change the needle, and it should be a long length needle. Whatever the tuberculin syringe is having, it is short length needle, and it can be nicely used, and the precise dose of adrenaline can be given, and it can be injected in the lateral aspect of the thigh. And speaking about the auto injectors, we are now we are dependent upon EpiPen, but very soon we will have, our country is fortunate enough that our two DOs, the two engineering students from Bangalore, they have bagged the Dyson award for developing the auto injector that will come with the name EP shot. So it will be a reusable auto injector, and it has been created by these two students, and they have bagged the James Dyson Award. So very soon, and we can reuse it. It is reusable. So that is the beauty of this EP shot. So this thing can be practiced, and whenever I am practicing, whenever I have myself has taken on 2 occasions. So I feel this tuberculin syringe. I change the length, the long length needle, and I can there was again the thing was there that it can be taken in the deltoid, but while taking in the this lateral aspect of the thigh, you can take it self on yourself. So this is the beauty, and it can be taken from the clothing itself. So this anterior aspect, lateral aspect of is the thigh is the preferred site for giving, and the tuberculin syringe with the needle can be taken. So this is my take on this previous question. Yes.
Thank you you gave a very good news. I had not known about this episode. This is a really good news for us in India. And the second question I wanted to ask you is whether you would recommend that all the doctors who do vaccinations in their clinic, wherever it is, should have adrenaline tray. And what about the health centers where vaccinations are done? Is adrenaline available there? And should it be made available?
So in every setting, whether it is OPD or IPD setting, we have to keep the adrenaline filled syringe ready. So because we cannot predict when this reaction, the anaphylactic reaction, can happen or can take place. So I have seen dentists, they are not ready, and they are practicing in a smaller closet. Small clinics are there, and they are not having any access. So I have taken session for this dentist also. So they can use it. Dr. Neeraj sir also mentioned in some lecture. So we can pre-fill this 1 ml syringe of tuberculin syringe, and it can be kept for days together. So I only think you have to change the needle, and it can be taken for 90 days. So once the color changes of this pre-filled syringe, so you have to discard it. So in every setting, we have to have this things ready with us.
Thank you, Dr. Abbas. I request Dr. Neeraj Gupta, sir, to please wind up for today's session and make the concluding remarks and his comments, if any. Dr. Neeraj Gupta, chairperson.
Thank you very much, Dr. Sanjupta. I think it was an excellent moderation. It is not very easy to moderate the stalwarts in the field, especially Dr. M.T. Krishna, Dr. Saibal Maitra, Dr. Sitesh, and Dr. Jahir. And that is also a difficult topic: peri-operative anaphylaxis, refractory anaphylaxis. So these are not the simple topics, but you made the day and the job very well. So thank you very much, and congratulations to you. I would like to thank Dr. M.T. Krishna, Dr. Sitesh Roy, Dr. Jahir, and Dr. Saibal for taking out some time from their very busy schedule and contributing to this webinar. And this marks the end of the 3 webinar series. And I would like to request everyone, all the listeners, that those who are still willing to learn more, so you can probably go back to our YouTube channel, and then all the 3 webinars are there on the channel, and then you can once again have a revisit. So thank you very much. Thank you, everyone. Thank you. Dr. Rai sir, you are on mute.
Yeah. No, I said thank you, and you all have a good night. That was a great session. Appreciate it.
Thank you, and good night.